Hi everyone. So today we're going to be talking about seizure disorders after reviewing a case study. And this is by Jonah, Jordan, Gabby, and Stephen. So some of our learning content that we're going to go over today is the pathophysiology and risk factors, what is tonic-clonic seizure, nursing diagnoses, documentation, assessment, medication and reactions, complications, and education. So we're going to start off with the pathophysiology of a seizure disorder. So seizure starts with the excitation of a cerebral neuron, and that leads to a synchronized effect to other neurons. Then you have glutamate, an excitatory neurotransmitter, and then gamma aminobutyric acid, also known as GABA, and that's an inhibitory neurotransmitter. When these neurotransmitters have an imbalance, it causes an abnormal electrical activity, which triggers that epileptic activity effect. Generalized convulsive status epilepticus is accompanied by systemic lactic acidosis, hyperthermia, and respiratory compromise. And then these issues is what causes damage to the brain, especially when there's respiratory compromise. Some risk factors, while they're not while there are many risk factors, some of the seizures that happen to people are undiagnosed and have no known reason why they experience a seizure. But here are some of the common ones that we found is brain tumors, abnormal blood vessels in the brain, infections such as meningitis, fevers, use of cocaine and illegal drugs, traumatic brain injury, abnormalities in newborn babies' brain, premature babies, family history, and Alzheimer's disease. Next slide, we're going to go over what a tonic-clonic seizure is. So this is also known as a grand mal seizure. That used to be the old name for it. So it starts off with the tonic phase, which is the stiffening, and then you have the clonic phase, which is the rhythmical jerking that you usually see with a seizure patient. So like I said, the tonic phase comes first. This is when all muscles stiffen, patients will lose consciousness and fall to the floor. They might bite their cheek or might have any oral trauma, so we want to pay attention to that when we're assessing our patient. And then the clonic phase, and this is when arms and legs start to jerk rhythmically. And then they may appear cyanotic, lose control of their airway, bladder, and bowel functions. Some important things about the tonic-clonic seizures, they usually last 1 to 3 minutes. Um, and then there's the postictal phase, which is when a patient finally comes to, they're a little bit confused, they might be irritable or feel sleepy, and this could last a wide range. Seizures lasting greater than 5 minutes or 3 consecutive episodes without a person coming to in between is static epilepticus and an emergent patient. Some of my nursing diagnoses are going to be ineffective airway clearance related to decreased level of consciousness and loss of protective reflexes as evidenced by abnormal respiratory patterns, cyanosis, and gurgling sounds. And then we have risk for aspiration related to impaired swallowing and reduced level of consciousness. And then we have risk for injury related to jerking movement, altered level of consciousness, and loss of motor control. Like I said previously, these patients are going to lose all motor function and their protective airway reflexes. So we want to make sure we have suction, airway management adjuncts ready to go, and oxygen as well.
For this next part, we're going to be discussing what to document specifically during a seizure episode. Not only is it important to document because we need to understand what the diagnosis is, what treatments we're using, interventions, but we also want to evaluate the effectiveness of everything we do. Is it working for the patient and is it not working for them, and why? Now, the documentation that we'll be taking should be factual, time specific, and free of any assumptions, meaning that we should be taking as many objective measurements as possible. Don't put your own bias or your own assumptions into what may or may not be happening. And there are three primary phases to document. This is going to be pre-ictal phase, the ictal phase, and the post-ictal phase. During the pre-ictal phase, this is also known as the time before the seizure, we want to know if the patient is having any aura, meaning do they see a cloudy visual field of different colors? Um, this can also be accompanied with strange sensations, smells, and visual changes. Now, it is also important to note the client or the patient's activity and location before the seizure began. Were they exercising? Were they watching TV or just watching different monitors? Um, which goes into the next point of were there any triggers? Were they in a situation or was anything happening that could have elicited the seizure episode? And then lastly, were there any unusual behaviors noted before the seizing happened, before the episode occurred? During the ictal phase, also known as the time during the seizure, we have a lot of things, a lot of important things to document. First is going to be the start time and the duration of the seizure. This is going to be directly involved in the diagnosis and what kind of seizure we as healthcare professionals are dealing with, as well as what kind of interventions we'll be doing. The type of movement observed is another form of diagnosis and how we can intervene and which path we choose to intervene. Um, for example, are they extending their body? Are they flexing their body? Is it jerking movements? The area of the body involved is incredibly important because it's going to correlate with what part of the brain is being affected. Respiratory status is an incredibly high priority system to maintain. So, are they breathing and do they have an airway? Understanding their level of consciousness and responsiveness is going to, again, play into the level of damage or the extent of seizure being or brain being affected by the seizure. Pupil changes, again, we're looking at neurological effects on the body. Incontinence, biting of tongue, and vomiting are systemic, secondhand, if you will, second damaging effects that are coming from the seizure. So it's important to get as much information from the total body as you can, as well as any injuries sustained during the event. Was there a fall? Um, did they hurt themselves? Things like that. Post-ictal phase, also known as the after part of the seizure, the post-seizure time. We want to know if there was any confusion and drowsiness, and if so, how long did that last? Did they recover from it? Are they still in it? Do they understand where they are, what they're doing, the year, the time, the place, their name? Are they alert and oriented? What is their neurological status? So again, looking at pupils, muscle contraction, sensation, orientation. Vital signs and oxygen saturation are basic high priority things that we should be documenting throughout this time as well as we can. Interventions provided, including medications like diazepam, airway support, and suctioning. It's very important that we document any interventions that we use. Um, so again, we know what is working and what is not. We can evaluate effectiveness. And then patient reporting, episode and symptoms like emotion status, complaints of headache, muscle soreness. This is where we get into the more subjective. How do you feel about all of it? There are six diagnostic assessments, but we're really going to focus on two because the EEG and CT scans are our main tests. An EEG is going to look at brain activity and brain signals to determine what kind of seizure and parts of the brain is damaged, while a CT scan can look if there's bleeding, a hemorrhagic seizure, and which part of the brain is that happening on. Everything else can be looked at as either taking pictures or looking at how many waste products, byproducts, imbalances there are in the blood and vascular systems.
Okay, today I'll be reviewing two common anticonvulsants used to treat tonic-clonic seizures, and that's dilatin and carbamazepine. Dilatin, taken at 100 milligrams 3 times a day, works by diminishing seizure activity. Its potential adverse effects include cardiac arrest, Stevens-Johnson syndrome, hepatic failure, angioedema, and suicidal thoughts. Carbamazepine is taken at 200 milligrams twice a day and helps prevent seizures. Some of its major adverse effects include hypertension, liver toxicity, Stevens-Johnson syndrome, pancreatitis, thrombocytopenia, and suicidal thoughts. Both medications are effective, but come with a serious risk, so patient monitoring is key.
Next, we have food and drug interactions. For Dilantin, IV used with dopamine can cause low blood pressure. Antacids can reduce how well oral Dilantin is absorbed, and they may also lower folic acid levels. Even tube feeds can interfere with absorption. For carbamazepine, interactions may include lowering nefazodone levels, which is an antidepressant, and when used too soon after MAO inhibitors, it can lead to severe outcomes like seizures or death. It could also increase the risk of liver toxicity when combined with isoniazid and CNS toxicity with lithium. Importantly, grapefruit juice can raise carbamazepine levels and risk of toxicity can occur, so it's important that it's avoided. Lastly, I want to cover preventative care strategies for managing seizures. The most important factor is medication adherence, taking your medications exactly as prescribed. Next is understanding and avoiding personal triggers. This can consist of stress, sleep deprivation, or flashing lights, and it can also significantly reduce seizure risk. Educating family and friends on seizure first aid ensures support in emergencies, and safety measures like avoiding unsupervised swimming or driving restrictions may be needed. It is also crucial to support mental health as anxiety and depression can increase seizure risk. And finally, schedule regular follow-ups with your neurologist to adjust treatment plans and monitor for side effects.
All right, let's talk about the complications. Seizures aren't just isolated events, they can have serious consequences if not properly managed. One of the most immediate complications is physical injury. Patients can fall and hit objects during these seizures, specifically the tonic-clonic or atonic types. Another critical complication is status epilepticus, which is a medical emergency. It involves a seizure lasting longer than 5 minutes or repeated seizures over 30 minutes without a return to consciousness. This can lead to brain damage, hypoxia, metabolic acidosis, or even death if not treated quickly. Medication-related issues are also common. Antiepileptic drugs can cause liver damage, blood cell disorders, and gingival hyperplasia. This makes monitoring lab values and patient education essential. Finally, the post-ictal state, the period after a seizure, can involve confusion, fatigue, and memory loss, and some patients may experience long-term psychosocial effects like depression or anxiety. As a nurse, we play a key role in educating patients and families. Here are the most important teaching points. First, emphasis on medication adherence. Patients must take their AEDs consistently and never stop abruptly. Teach them how to identify and avoid seizure triggers like sleep deprivation, stress, alcohol, or flashing lights. Encourage the use of a seizure diary to help identify patterns. Next, we'll talk about teaching safety precautions like turning the patient to the side during a seizure, never forcing anything in their mouth, and only calling 911 if the seizure lasts more than 5 minutes. Then lifestyle modifications. They should wear a medical alert bracelet and know their state's driving laws regarding epilepsy. And lastly, connect patients to resources like the Epilepsy Foundation for support and additional education. Now, how can we apply this to practice? First, always ensure seizure precautions are in place. This includes having suction, oxygen, and a saline lock ready for high-risk patients. We can promote medication safety by checking for side effects, monitoring drug levels, and reminding patients about the importance of regular labs. During patient teaching, use the teach-back method to make sure they understand their medications and seizure plan. We can be proactive in interdisciplinary communication and make sure everyone on the care team knows about seizure history, triggers, and any recent changes. We can also encourage patients to adopt a healthy lifestyle, including adequate sleep, nutrition, and stress management. And then finally, support their mental health and social well-being, understanding that stigma and fear can impact quality of life, and connect patients to counseling or peer groups as needed to help with that as well. And finally, here are our references we used. And here's the end. Please feel free to reach out if you guys have any questions, and thank you for listening.